But I want to introduce our speaker without further ado, Dr. Michael McDonell, who is an assistant professor in the Department of Psychiatry and Behavioral Sciences here at the UW. He's also an attending psychologist at the Center for Foster Care Health at Harborview Medical Center. And his current research focuses on evaluation of treatment strategies to improve treatment engagement and to reduce substance use in persons suffering from serious mental illness and stimulant disorders. And his research also focuses on evaluation of child psychiatry consultation in primary care settings through the Partnership Access Line, PAL. In addition, Dr. McDonell studies adaptation of current empirically supported psychosocial interventions and engagement strategies for youth, particularly those with serious mental illness, and those in foster care who are transitioning from adolescence to adulthood, with a focus on preventing long-term disability with these populations. So without further ado, I will turn it over to Dr. McDonell. Let me pull up your slides here. Okay. All right.
So today I'm excited to be here, glad to be here. I had a little hard time finding this building in this room, although I spoke here last year. So I apologize for being a little late. So I'm here to talk today about the two kind of areas that I'm involved in. One is in assessment and treatment of individuals with serious mental illness. And who knows what I'm talking about when I say serious mental illness? What diagnoses do typically encompass those? Schizophrenia? Excellent. Excellent. Nice work, I'm impressed. So the typical federal definition of serious mental illness are the diagnoses of schizophrenia or schizoaffective disorder, which is a combination of a mood disorder and schizophrenia, bipolar disorder, and kind of recurrent chronic depression. Not depression that you go to your primary care doctor and get an antidepressant from, and that seems to really work. Or go to a short, brief cognitive therapy, and that seems to be effective for you. For folks, when we talk about serious mental illness, we're typically talking about individuals who suffer from chronic, kind of long-term depression. And so for the most part, most of these individuals are served in our community mental health centers. So as social workers, you all are going to be involved in care for them if you're involved in that kind of a setting. So so this is my slide. So we see this a lot around Harborview. There'd be people who are walking around and I'm kind of a little concerned for them. And then I look and they've got a Bluetooth headset in. And sometimes I'm a little more concerned for them. So anyway, sorry. So thought we'd start off with that. So basically the talk today is going to be about the overlap between the adult mental health system and and for the most part, the adult mental health system serves people with serious mental illness. That's who community mental health centers serve for the most part, with exceptions. However, the child kind of public health system doesn't serve those individuals. One, for a good reason, which is that those diagnoses don't typically occur until late adolescence, early adulthood, which makes good sense. However, some of you, as you get into practice more, as you've been in practice or in life experience, you've realized that a lot of these, especially because many of you are college-aged, typical college-aged students, these illnesses do develop during this time and can develop in high school and even earlier. And we'll talk a little bit today about the controversy about some of these disorders developing earlier, but not too much, because we could have a whole day workshop on that. So in the children's mental health system, we typically talk about seriously emotionally disturbed children. Doesn't that sound horrible? I think there's other definitions of that acronym. And what that is just any psychiatric or psychological disorder. It could be ADHD, it could be oppositional defiant disorder, could be depression, and then a certain level of overall impairment. So in the child mental health system, in King County, you have to have a certain diagnosis, let's say depression, but that's not enough to be served by the community mental health centers. You also have to have a level of impairment, overall impairment, to the extent that you could then be served in that setting. So you can't just have a little depression. You're in addition supposed to also have depression to the point that it's impairing your ability to function at school or function at home, et cetera, et cetera. So what we're going to talk about today is that some of these kids who you might see, here if you see children, especially as they enter adolescence, may develop these kind of problems. And so often some of the biggest challenges as far as diagnosis and treatment come into play when you're working with an adolescent who maybe has had ADHD and depression for a while, but now all of a sudden, is reporting that he thinks that he can control the planet's orbit and has some very specific ideas around that. And so often we're thrown for a loop by that. And what's that about and how do we figure that out? Any questions or comments about that before we go on? Uh-huh.
Would you just talk about what you have access to question?
Yeah, so in the federal definition, so access to in the DSM-4 is any kind of a personality disorder. And in the kind of federal definition, they typically limit the federal definition to schizophrenia and bipolar disorder and recurring major depression. But a lot of folks, including myself, I work at the dialectical behavior therapy clinic in Harborview, really feel like many of the people that are in a community mental health system also suffer from things like borderline personality disorder or antisocial personality disorder. So that's not really included in the official definition, but often those people are served in our community mental health centers, those individuals. That's a good question. So why talk about this overlap, particularly in adolescents? Well, they're obviously, as I said, they're disorders that present during that time period often. They present unique challenges to mental health clinicians, particularly in the child system, where the focus in the child system is often on, we like it many of us at our Evidence-Based Practice Institute would like it to be more on psychotherapy, but it's often on working on psychotherapeutic services for things like parent training for oppositional defiant disorder or conduct disorder, individual therapy and family therapy for depression. There's a lot of focus on actual psychotherapy in addition to medication. In the youth system, so there's often little expertise amongst folks. Many of us work in a child setting, and we don't really spend a lot of time as a result working with people with serious mental illness. So when we're faced with that possibility of that diagnosis and treating that individual, it can be often overwhelming, or we don't feel like we have the expertise to do that. And then in addition to that, there's a lot of controversies about, how many of you are aware of the controversy about bipolar disorder in children? Okay, everybody? Okay, good. It's on Time Magazine. Charlie Sheen's bringing it back up, although he's not a child. He's acting like one, but I wanted to have Charlie Sheen somehow in this talk, but I couldn't figure out a way to do it. So there's a big controversy in the field. This controversy is also true in the adult field too. So there's a controversy about what bipolar disorder means, whether it's a yes/no kind of a diagnosis or a spectrum in adult psychiatry. And in child psychiatry is even a bigger controversy. So we'll talk a little bit about that today, but again, not too much. But there's often, this diagnosis is a really tough thing. And we're going to talk some more about what that means. To make these diagnoses in adolescence and as you go younger and younger, it's even more challenging. So, many of you are not old enough to remember the Kennedy assassination. I'm not either. So, the idea of this slide is that often we look for explanations that are exciting, right, of events that happen in our lives. We look for explanations that seem to, if we can put all these different pieces of this puzzle together, it seems to make a really nice explanation. So, there was a shooter on the other hill or whatever. There's 3 people who killed John F. Kennedy. It was space aliens, it was the mob, it was Castro, whatever it is. So often this is kind of I think it's a correlation, not necessarily a direct correlation, but it's a similar thing when it comes to, let's say, childhood onset bipolar disorder. People are often looking for a complex explanation for a complex problem, or a really meaningful or really traumatic problem. So when you believe that your son or daughter has childhood onset bipolar disorder, you're maybe willing to accept multiple explanations, including a relatively complex explanation of things. So the important take-home message from today is Occam's razor, right? Which is that when you hear hooves, it's zebras. Okay? It's zebras. It's probably that a lone gunman killed JFK, not that a whole bunch of folks got together and spent years planning it and are now hiding in Brazil someplace. So, which may be true, I'm not saying it's not. But the idea is that for even complex phenomena, the most elegant and simplest explanation is often true. We want to look at things, we want to look at the science, right, of base rates, of how often these things, based on what we know about psychiatric illness, how often do these things occur in adults? And then how often would they occur in children? We use research and other ways of explaining things in order to come to, not necessarily always the simplest one kind of thing explanation, right? Not just bipolar disorder, but it's much more common for children to have ADHD and depression, right? A lot of kids who have ADHD have depression. A lot of kids who are depressed have ADHD. So if a kid presents to me with a lot of hyperactivity and he has elevated mood, lots of mood swings, and also seems to have times of depression, that's probably a more likely explanation than bipolar disorder. So we'll talk about that a little bit more. But the basic idea is that all these diagnoses, in particular bipolar disorder, so we're really going to focus now on bipolar disorder and schizophrenia, those are diagnoses of ruling out all other explanations first. So that's the take-home message of this slide. So the first thing we want to do is kind of figure out, for bipolar disorder, and certainly true for schizophrenia, we have a pretty good idea, not of what what causes them necessarily, but we have a pretty good idea of how often they occur. Schizophrenia particularly seems to occur across the planet at about 1% in almost all populations. So when we take into account cultural considerations, what we find is that it's about 1% across cultures, give or take some. So the onset is typically the mid to late 20s. For the men in the room, it's going to be earlier than women in the room. So for women, men, it's typically in your early 20s. Women, it's typically in your late 20s to early 30s. So already if a 12-year-old girl walks into your office and her parents think that she has schizophrenia, right, you want to be a little bit more, not suspicious, but a little more guarded in where you go and what you do next, and really make sure that you're ruling out other causes. Adolescent onset, so anything under 18, is relatively rare. It's hard to do studies of rare phenomena. Most of these studies tend to come out of rare things. Most of these studies tend to come out of socialized countries in Northern Europe, who maintain large data systems and really track folks. So it's rare, 14, and it's very rare under 15. So when you move into 15 and younger, we're looking at 14. The best numbers we've got are 14 out of 100,000. So again, very unlikely. And very early onset schizophrenia, which is 12 and younger, is extremely rare. There's some folks like Dr. McClellan in our department who are experts in this kind of assessment of and treatment of very early onset schizophrenia. And so that's even more rare, and that's more typical in males and boys. Uh-huh.
How accurate is the epidemiological data for under 18s compared to adults?
That's a good question. I think the data is. I think that there's a shorter duration of data. We've only really studied this problem for the last really 10 to 15, 20 years. So we really know, there's been a consensus about what schizophrenia looks like in adults for a long time. So they've really, we have some studies coming out of China and out of the Chinese famine. I think that was in the 60s, 50s, 60s, and then also out of World War II in some of the Northern European countries where they've been tracking people since then. So the data are less robust. I think, though, that the data are really consistent that it's extremely rare, no matter where you look. That's a good question, though. So what is schizophrenia? And I've kind of tailored this to adolescent onset schizophrenia, so we're going to talk in this slide about a little bit about what's consistent or more likely to occur if you're an adolescent versus an adult who's presenting with schizophrenia. But these are kind of the hallmark symptoms of schizophrenia in general. So the first thing is positive symptoms, right? Which doesn't mean that there's three categories. Positive symptoms are not something good, right? There's something, if you have the diagnosis of schizophrenia, that's added, that you've got that the rest of us don't have, unless we're using hallucinogens or something. So, or we're having a really bad day. So the first one is hallucinations, right? Typical hallucinations come in what form? Are they visual, auditory? What are they most, if you have schizophrenia, what's most likely to occur? Wow, very impressed. That's excellent, yes. And if they're visual, primarily visual, you should really look for other causes first, like drug and alcohol use, brain injury, tumor, something like that, more typical. So the other hallmark is really delusional thinking. Thinking that's delusional, and delusional doesn't mean just a little strange, because there's a lot of people who have strange thinking. Delusional means that it's outside of reality. That most of us in this room would sit there and hear this person's story about the aliens coming and aliens being in special contact with them through the TV and think, wow, okay, that's outside of the range of normal. So the idea with delusions is that they're outside of the range of what most people would feel is culturally appropriate or appropriate for a person's religious beliefs. So that's the positive symptoms. The thought disorder, schizophrenia is a thought disorder. That's another take-home message. If a person presents to you with schizophrenia and they're not on medication and they're going through an acute exacerbation of their illness, it is typically going to present as a thought disorder. They're not going to make sense to you. And it's not going to be in a way like a kid with ADHD is, who kind of goes off onto topics and then can sort of come back or kind of talks a little bit too much about what they want to talk about. That what we call loose associations will happen within a sentence. So I might start my sentence talking about one thing, in the middle I switch to talking about something completely different, and at the end you're looking at me like, I don't understand at all, I have no idea what you're saying. So the idea is, and this again is on a continuum, it's not necessarily always true for everyone, but loose associations, illogical thinking that just doesn't seem to make sense, impaired discourse skills, not using language grammatically correct fashion, really not really responding back to nonverbal and other cues that you'd see from that you typically respond to. And less common in kids, so this part is less common in adolescents and in children, is that they typically don't appear incoherent. And then another thought disorder problem that adults with schizophrenia have that children don't and adolescents don't have as much is really a poverty of thought or a poverty of speech. So when you often talk to a person who's going through, suffering from schizophrenia, and they're not doing very well, you'll ask them a question like, so tell me about your mom. Her name's Nancy. Okay, thank you. How about your dad? What's your dad like? He's really nice. So what typically people who are suffering from schizophrenia and they're not well medicated, they're not in recovery, they'll have a poverty of what they're actually thinking. So it's not like they're poor. They often are poor because of their illness. However, the poverty is really just the amount of thoughts they have going on in their head. That front part of the brain that generates our thinking and tells us to express it, it's not functioning very well. So there's often a poverty in speech or thought content. That's less true in children. The thing that really helps you diagnostically differentiate children with schizophrenia or adolescents with schizophrenia versus other disorders is going to be negative symptoms. So negative symptoms are a really good way to tell what's going on, and they're the most likely symptoms of schizophrenia to present in children and adolescents. The younger you get, the more likely you are to see negative symptoms. Very few people under the age of 12 who do have verified schizophrenia, however we can verify it, based on expert opinion, right? We can't. That's the important thing to remember about psychiatry, right? In mental health, we cannot give someone a brain scan. Some people say we can and make a definitive diagnosis. That's just not accurate. The science isn't there yet. But what we do know in children who experts have agreed that they present and they have a diagnosis of schizophrenia is they typically have negative symptoms. So what you often see is that folks, and this is again, that things are taken away. Things that they had before are taken away from them. So they're not motivated to get out and do what they need to do. The poverty of speech part kind of overlaps here. There's a change, though. An important thing here is a change. It's a change from your typical functioning. So the child may have been a little unusual or different before, but this change in functioning is substantial. So you'll see big changes in the kid all of a sudden doesn't take a shower at all. When it was a 15-year-old boy, he used to really care about his hygiene. All of a sudden, he doesn't take a shower. He wears, a really heavy coat in the middle of the summer. Wears sunglasses all the time, wears headphones all the time, doesn't talk to anybody, isn't hanging out with friends anymore. When you talk to them, they have very little to say. They seem very guarded. Those are the negative symptoms. So questions about that before I go on. Again, the younger the individual, the more likely you are to see these.
How do you think, you don't have to address this if you don't want to, but I sometimes wonder about differentiating people with extreme anxiety versus some of this, because some of the OCD stuff is pretty thought disorder-y.
Yeah, it's a really good question. Excellent question. So I think it's a difficult differential diagnosis. The typical thing you look for is whether does the person believe that or have an idea of how much this is anxiety or a symptom external to them versus how much do they really believe that it's true. So often, folks with OCD, even pretty severe OCD, will be able to say, look, I know this isn't going to happen. I mean, I'm kind of sure it's not going to happen, but I really think it is. And so there's some insight into that. Whereas people with a really active form of schizophrenia, there's not so much. However, that being said, people with schizophrenia can have OCD, people with OCD can have schizophrenia, and often there's some people with really severe OCD that have especially younger children, that have very little insight into their disorder, and so that can often appear psychotic. So you really do want to look at, how far out of reality are these kind of, is it for things like, locking your door? Well, most people would agree that, if you're really worried, if you have a lot of anxiety, you're going to be more likely to check your door a bunch of times. There's other forms of, of OCD that kind of where people believe they step on a crack, plane's going to crash in Africa. Well, that's a little bit harder to kind of make that distinction. So that's an excellent question. I think that really relies on referral to specialists, multiple opinions, watching kids across time, or adults across time. Anything else? I'm going to keep going because of time. So the onset of schizophrenia is typically characterized by first a prodromal phase, which are subclinical symptoms of the disorder. So, some of you probably heard that, they've got videos of kids with schizophrenia, adults who have schizophrenia who were videotaped as children playing, and they have some idiosyncratic motor movements, or they seem kind of unusual even then. As you get older and older and you approach the kind of onset of schizophrenia, what often can happen is you have sort of these subclinical symptoms where your thinking becomes a little unusual, you don't start to hang out with friends as much, but your mom and dad just kind of think it's suspicious or unusual, right? They just think, but they don't think it's a big deal. And then what can happen is that can either get gradually worse and worse and worse until somebody finally comes to someone's clinical attention and makes a diagnosis. Or what can happen is that it acutely gets worse. So sometimes, I've seen this in a couple of cases, where the kid was functioning a month before pretty relatively normal, a little quirky, always a little different, functioning pretty normal up to that point, and all of a sudden started believing that he was being followed by the CIA. And I'm just making a typical example. Believed that he's being followed by the CIA and he had special powers and that he was a secret agent of a foreign government that was really a shadow government for an alien organization. And this is, again, pretty atypical of a kid because they're not going to have this developed of delusions. So he had delusions and hallucinations with a very quick onset. That's actually good. For a long-term prognosis, if your onset is rapid and you don't have a lot of those negative symptoms, your long-term prognosis is good. It's not being naked, running out in your front yard, screaming, the world's coming to an end, terrifying your neighbors, right, or your parents. That causes you maybe to go to the hospital for a couple days and start medication. But it's this kind of ongoing negative symptoms and this slow onset of the disorder that really keep you from getting a job, keep you from going to your appointments, keep you from taking your medications, and really get in your way. So that's kind of the idea behind onset. The younger a child goes, the younger a child is with schizophrenia, the more likely they are to have an insidious onset, or kind of a long-term gradual onset of the disorder, which makes the diagnosis even more difficult. The younger you are, the more likely this is to be a continuous lifelong problem, and the poorer your outcomes are. So the younger you're diagnosed, it kind of makes sense. The younger you're diagnosed, the more likely you are to have long-term problems. But for most people with schizophrenia, it's a long-term illness, it's a chronic illness. There's some data that kind of questions that, and there's a big debate about that, but it's typically long-term chronic. So I'm hoping we're doing okay over time. Best practice assessment. So Dr. McClellan and I wrote a chapter a couple years ago on this topic, and really the most important thing you want to do is, again, go through and rule out all other explanations first. And in doing that, you'll come to the conclusion that this is all you're left with. That's the idea of a diagnosis like this. So the first thing you want to do, just like any other assessment, is you want to do a multi-method, multi-informant assessment. Particularly if you really do think a person has adolescent onset schizophrenia, let's say, it's unlikely that they're going to have a lot of insight into their problems. So you're really going to rely on observations of teachers, of parents, of peers often even, to get information about their functioning in the real world. The other thing you have to do is a comprehensive medical exam that includes a toxicology screen to really see if this individual's using drugs. And get other information besides a toxicology screen to really assess whether or not there's drug use going on. They can also happen together, right? So it's not saying that if they're using drugs, that's a better explanation for their psychosis. But for things like methamphetamine addiction, especially in young adults or adolescents, that could be an onset that looks pretty similar to schizophrenia. So you also want to rule out things like for if you have manic symptoms, we'll talk about this in depression. You want to rule out thyroid conditions. You want to rule out brain tumors. Those are kind of typical things you are going to want to rule out. You're also most of these children, most adolescents who present with schizophrenia have been diagnosed with, I can't remember the exact numbers, but 7 other diagnoses before, have been through like 11 other treatments before. They've been through the mental health system and the educational system often for a significant time in their life. They've had kind of chronic ongoing problems. They've had other diagnoses before. Not that they're wrong diagnoses, but they've had other diagnoses before. So a really thorough record review is another important thing, and a tool that I use a lot that most people often don't use and don't consider. Because what you're really looking there is to look how long is that onset and how insidious has it been. Have you seen a sudden change? So if you're trying to rule out, if a person presents with a lot of negative symptoms, not a lot of interest in social relationships, trying to determine if this person has an autism spectrum disorder or schizophrenia, you really are going to want to look to make that distinction. You're going to see that that person socially was functioning pretty normally up to, age of, that's whatever the age is recently, like 12 or 13, and then all of a sudden their social functioning just deteriorated. So that would be more likely a schizophrenia onset versus something like a high-functioning autism where you would have always had, right, a developmental delay in kind of social communication. The other thing is observation, mental status exam. A clinical administered structured interview is typically really important. Relying on asking the right questions yourself is not always a good idea. Really using a structured interview and having a person who's trained to do that make the diagnosis, or at least have that as part of the diagnosis, is really important. Again, more to rule out other explanations so that you're not just tracked in on one diagnosis, but you're also going to ask, again, these structured interviews, the idea is that they have all the assessment questions you need to ask for all the diagnoses that you would want to consider. So you're not going to just, by nature, all of us as clinicians are really targeted on just, if we have a hypothesis, we really go for that hypothesis. And we try to rule out other things. But for the most part, if we have an idea about a diagnosis in the first few minutes of an interview or an assessment, our data typically will support that, or our conclusions would typically support that initial impression. So clinician-administered interviews are really helpful at kind of opening up your mind to other possibilities. Mental status exam, observation is important, data from all the collaterals like I talked about, and really time. Honestly, time with that patient, and I'm not talking about days, I'm not even talking about months necessarily, I'm talking about 6 months to 2 years. The longer the amount of time you have to assess, and that's not saying you won't treat the patient, but the longer you have to assess them, the better, and the more you can feel confident in that diagnosis. So we're going to move on to bipolar disorder now. And again, I'm for the most part going to talk about adolescent onset bipolar disorder, because most people who present with most adults with bipolar disorder report symptoms in their adolescence. It's very consistent. And so there's definitely young adults and adolescents who are manifesting or experiencing the symptoms of bipolar disorder. Again, the younger you go, the more of a debate there is, and the less common it is. So first, let's talk about if this is an adult disorder with an adult definition, what are the rates in adults of bipolar disorder? So as you can see, for bipolar 1, they're comparable to schizophrenia. And there's some range there, but they're pretty rare, right? It's less than 2% of the population. In a lifetime will suffer from this. When you also include things like bipolar 2, so bipolar 1 is kind of your classic up and down like this, where a person has a lot of symptoms of mania, right? Their elevated mood. Their mood is too high given what's going on in their life. They're too excited, they're too fired up, they're acting like Charlie Sheen on TV. And then what often happens is, he's saying he doesn't crash. So you then crash into a depression after that. That's typically worse than most people who have just major depression. And then you may come back to a level of stability for a while where your mood's normal, relatively quote-unquote normal, and then that goes back up and down. But for the most part, it's up and down for weeks, if not months at a time, with periods of just feeling normal. So that's bipolar 1. Bipolar 2 is kind of a mix of that, where you might have a mix of those episodes together. You might have manic symptoms for less than the week that's required by the DSM. So it's a little bit more up and down, or a little bit less typical of this kind of the bipolar part, or the manic depression. Manic depression is so much of a better term to describe this disorder. So bipolar 2 is again, relatively rare. And then some folks have taken a really pretty general definition and found that up to 6% of individuals who are adults could be diagnosed with this. Contrast that with before here, the range we've got here. So from folks at Sale Children's did a study in young children, really young kids, they found that 0.6%, so basically I think it was one kid, out of this whole study had bipolar disorder, met criteria for bipolar disorder. The other range is 22%. And some people are even saying higher. And so a sample of preschoolers, very similar to the group in Seattle Children's. Another group back in Boston did a study, I think, or St. Louis, and they took that exact same, they were basically kids with early onset behavior disorder problems, like early onset ADHD, early onset ODD, and they did almost the exact same study and found almost 50% of those kids met criteria for bipolar disorder. So you gotta kind of shake your head and think, well, what's going on here, right? This also seems to be a U.S. phenomenon. Adolescent and childhood onset bipolar disorder seems to, especially the younger onset bipolar disorder, seems to be really limited to the United States, at least in current studies. I don't know in past studies that have been published. I don't know currently if this is still true. So, but again, 50% of adults report their first symptoms younger than 18. So it's an important topic, and you're more likely to see this presentation than you are with schizophrenia.
When we look at maybe less than 1% as a general preference, but then I think working in a mental health system, you see really concentrated family members and so on. So it's kind of only 1%, but then likewise. So I think that's a really good point. So these are general prevalence estimates from the community. So when you move to more of if you move to a treatment-seeking population, they're going to be much higher. Although that's not entirely true. This 6 to 22% comes from a treatment-seeking population. They're young. Some of those are treatment-seeking populations. So that could be a good explanation for why that's higher than the numbers up above too.
You're definitely right, especially if you work at the bipolar clinic at Children's. You're going to see more kids too. But you're right, though. You're definitely right. People send me more kids than I would generally see who have bipolar disorder. So Youngstrom and colleagues who are really the kind of, some of the folks at Seattle Children's or in our department in general are pretty conservative about our definition of what bipolar disorder is and really rely on the adult definition. Some groups in Boston and in St. Louis that really rely on a very general definition that many of us in the room might meet for childhood onset bipolar disorder, although we're not kids. So Eric Youngstrom is really I feel like is a person who's kind of in the middle. He's a real scientist, but is also willing to accept the idea that these things, that a more general definition or a more developmentally appropriate definition is appropriate for children who may be suffering from these problems. So these are the symptoms that he's found really differentiate people who have, children who have bipolar disorder, or adolescents who have bipolar disorder from those who don't. The one is really extreme impairing situation, inappropriate mood. So the idea is that all of us get down when bad things happen to us. And all of us get excited when good things happen to us, most of the time. But when a person has bipolar disorder, they don't necessarily. So if bad things are happening to you and you have mania, you're likely to be manic. You may respond to that stressor in a certain way, but you may not get depressed about it. You may continue to have elevated mood. Grandiosity is episodic and it's tied to mood. So again, the idea is bipolar disorder is a mood disorder, so any symptoms that go with it should be tied to the changes in mood. So if I don't sleep, it should be tied to a change in my mood. If I sleep too much, that should be tied to my change in mood. If I don't eat enough, that should be tied to my change in mood. So the other one that he's clear about is that it's decreased need for sleep, not insomnia. That's the difference. If I have an anxiety disorder, it's really hard for me to get to sleep, right? If I'm under a lot of stress, it's really hard for me to get to sleep. But in bipolar disorder, it's typical that you wake up the next morning, you didn't sleep last night, and you're ready to go, right? Or you're more ready to go than other people might be. So there's other ones. The biggest one, the most important one, the hallmark of this early onset bipolar disorder is really this tantruming idea. So this debate in the literature about what a tantrum means, or what intense tantrums mean, and are they a sign of bipolar disorder? And so we had an expert come out and give grand rounds a couple of years ago an expert in childhood onset bipolar disorder, and she was saying that tantrums are like the fever of psychiatry. And so the analogy I think really fits for me because a fever just means something's wrong. Your body's responding and trying to battle something. It doesn't tell you what the diagnosis is. It could be a number of any thousands or millions of diagnoses. Things could be going wrong. So a tantrum is a good example of a symptom that's not diagnostically specific, basically, is the idea. That if I have a tantrum, I could have ADHD, I could have PTSD, I could have that, I could have bipolar disorder. The idea is it's not specific to diagnosis.
Or it could be not a diagnosis at all, right?
Yeah, well, we'll talk about that.
Right?
Yeah, yes. Yeah. So yeah, there could be multiple explanations for that behavior's occurring. Exactly. So we'll talk about how it is a disorder, though, possibly. So this is the new kind of, I don't know if this is a solution to our problem or another problem. But these are the diagnostic criteria, and I've edited them because they're very long to get them onto a slide. So temper dysregulation disorder with dysphoria is a new childhood disorder that's been proposed for the DSM-5. And this is basically the idea is that this is a kid who presents, like many of the kids that you all have seen probably or will see in your careers, as a child who has a problem with temper tantrums. They're intense temper tantrums. They involve aggression, verbal or violent or physical violence. They typically also maybe involve destruction of property, so intense tantrums that are also related to mood. They're responses to common stressors that you would think for most kids would be like, what? You don't need to get that upset. And as a parent, I often say that. But in addition to that, really most people will be like, wow, like these are the phone calls you get from teachers saying, oh my God, what do I do? So the reaction is grossly out of proportion to the situation. The responses are inconsistent with the developmental level. So again, it's not toddlers often have a lot of problems. I have one with emotion dysregulation, and they have a lot of issues around that. They're very frustrating. However, that doesn't mean it's a disorder. It may be developmentally appropriate. They occur on average 3 or more times per week. That one I kind of struggle with because I work with a lot of kids who have 3 or more tantrums a week. With a lot of adults who have 3 or more tantrums a week. And that's just in our department. Okay. between temper outbursts, the mood between temper outbursts. The idea is, criteria C is really that the kid has mood problems when they're not having a temper tantrum. So this has kind of been thrown in as it's not going to be categorized under a mood disorder. It's going to be a separate under child early or diagnoses that present in childhood, similar to autism or ADHD, and it's maybe included in our new diagnostic symptom. The other issue is similar to ADHD. It has to well, not similar to ADHD, the first point, but chronological age has to be before the age of 6 or older, and it has to, similar to ADHD, present before 10 years of age. ADHD I think is 7, but it has to start early in life. All right, so that's that. So before we move on to evidence-based treatment, does anyone have any questions about that or comments?
Are you going to talk about how the treatments might be different between that diagnosis and bipolar? Between
schizophrenia and bipolar, or between this I can. I don't know if I know, but I will talk about it. We could definitely talk about it. So I don't know what's actually going to play out. I can tell you what I think should happen in terms of diagnosis, difference treatment. So other questions about that, about things around diagnosis? So again, take-home points are rule everything else out first, get a comprehensive medical evaluation, use that child's records because they're probably going to have a lot of, or adolescent's records, probably going to have a lot of records. If you have the luxury, although we don't always encourage this, of getting observations, really comprehensive observations, like sometimes these kids will present to you discharged from an inpatient unit. That's where you really want to use those records because they've had a long period of observation, often without medications that can really inform your diagnosis. And I think the other important thing is really to consult with experts. We have a lot of experts in our department that I'm sure would be glad to talk to anybody about kind of making a differential diagnosis around this or accept referrals if you're willing to tolerate long wait lists. All right, so this is a former evidence-based treatment, although I don't know what it's for necessarily. I think I was just corrected. It was described on a webpage. This is why you got to be careful on the internet. It's described on a webpage as insulin shock therapy. However, when I was just meeting with a pediatrician and showed her this slide, she said she thinks this guy's just is being fed through a tube. So it may be actually evidence-based. So this is a pretty blank slide. It's going to get filled up, I hope, in the next couple of years with some of the research that's ongoing right now. So the take-home message is that for most of for bipolar disorder in youth and for schizophrenia in adolescents and young adults, there's very few empirically supported treatments specifically for adolescents and children. Very few treatments. Most of these treatments, we have a pretty good foundation of research supporting them as treatments for adults. But again, like many other child psychiatric problems, we're going to say, oh yeah, if it works for adults, it works for kids. So with some modifications. So we're going to talk a little bit today about kind of what the evidence is out there now, and particularly what the evidence is for adult populations, because I think most of these things do fit for kids too. So first-line treatment for both bipolar disorder and schizophrenia remains medication. There's now a few of the atypical antipsychotics, the newer antipsychotic medications are approved for childhood onset bipolar disorder, or not I should be careful, early onset bipolar disorder, adolescent bipolar disorder. And I think there's recent studies, including but done by folks here, that show that lithium can be effective for people who do have bipolar disorder, the conservative definition of bipolar disorder who are adolescents. There's also pretty good evidence that antipsychotic medications are effective for children with early onset schizophrenia. So medications, there seems to be more and more recently, again in the last 5 years, as opposed to the last 20 years, there's been more and more evidence saying that medications work for these individuals. Back to your question about if they have this temper dysregulation disorder though. So the evidence there's been some research on this really general definition of bipolar disorder and treating those kids with medication. If you are doing clinical practice right now, or if you're, whether it's a practicum or you're actually in full-time clinical practice, you're seeing a lot of kids who are on atypical antipsychotics, I imagine. And the evidence base for that, for this more general bipolar disorder definition, this more open definition to bipolar disorder, the bigger spectrum, there's not really good evidence for that. And in particular, for this temper dysregulation disorder, that would not be my treatment of choice for that. Treatment of choice for that would be a parenting intervention, similar to ODD or oppositional defiant disorder or ADHD. So along with maybe some parent management around depression and support of parents around depression, and as the kid gets older and older into adolescence, so maybe individual therapy for cognitive behavioral therapy for depression. So again, case management is the other thing that's not so emphasized. So you all as social workers are really important in this area for these kids and these adolescents because they need case management. Their families need case management because they don't know what to do. If you can imagine, if you're in the shoes of the parent or of a teenager who's going through this, it's an amazingly overwhelming experience, and you really are going to need case management and support around that. Most of the evidence-based psychosocial treatments are family psychoeducation interventions, we call them. They're family psychoeducation and support interventions. So what they really focus in on is teaching the individual with the illness and their family members and their significant others and their friends, if they want to be involved, really what the illness is, what the causes are, how to manage it, and how to prevent relapse. So and we use basically the literature we know on adult populations of what predicts relapse. And we use that literature, so things like intense family emotions. So family members, and again, they don't cause schizophrenia. I want to make sure that's clear. Family members do not. It's a genetic-based disorder that has an environmental component that we don't entirely understand. However, we know that for people who do have the illness, if they live in a family that's very hypercritical, a lot of yelling, a lot of hollering, they are more likely to have relapses. If they live in a family who's very supportive or a low-key, easygoing family, not like my family at all, then they're less likely to have relapses. So when we do a family education for schizophrenia, we really work towards reducing what we call expressed emotion in the family and helping family members use other ways of communicating so that they can support the person's recovery. The other promising approach is that there's a group, there's Stephanie Listala here who's doing research on a specific evidence-based treatment for adults with bipolar disorder in adolescents. And then there's also some evidence coming out of a group, I think she's even colleagues with these folks back in Pittsburgh, using DBT to target young adults and adolescents with bipolar disorder. So our time is up at 1:20, is that right?
I think we probably go over 5 minutes, but some students might have to go to class for 1:30.
Okay. So let's see, before I go on to that, any questions or comments before I go on, really quick? Should I answer any burning questions that you want to ask and you don't want to miss before you go to class? Okay. Go ahead.
Is there any evidence that the presence of symptoms of something in the bipolar spectrum disorder category, like psychothymia or something, maybe in an adolescent, may lead to, like if that, they kind of meet the criteria for psychothymia as an adolescent, does that lead to bipolar disorder as an adult, or is it more?
Yeah. That's a good. Well, no, that's a really good question. I think I understand your question. So what we know is that so I'm going to take a step back and answer your question a little differently. There's been a couple studies done with adolescents who present to an inpatient psychiatric unit where they're diagnosed with the really conservative definition of bipolar disorder, and then they're followed for 5 years. And what they found is about half of them 5 years later, don't meet criteria anymore. Or a substantial proportion of them don't. So there's even debate about how stable things are. There's a real debate about psychothymia and whether or not that should even be included as a diagnosis at all. But you're kind of saying the more general kind of definition of bipolar disorder. Yeah, I think that's the question I have actually. And there's been a couple of studies. There was a really good study that came out in a really great journal. I got it. It said long-term course of childhood onset bipolar disorder. And I thought, wow, this is great because they followed them all. They got paid a lot of money. They followed them a long time into their young adult life. And so what they did is instead of assessing them for that kind of psychothymia and then assessing them for the more typical definition of bipolar disorder later in life, they didn't do that. What they did was they assessed them for basically like psychothymia in adolescents and psychothymia when they were young adults. And lo and behold, they both had the same. So I don't know if the research, I think yes, there's some evidence for that. And I don't think the research studies have been set up like that. Partially because there's these camps, these kind of beliefs, philosophical beliefs about what bipolar disorder is, and they don't necessarily overlap. So it's a really good question. But I think my tendency is to say yes, that they'd be more likely. Any other questions before I go on? So talk really quick about one evidence-based intervention. We'll talk about this one. I've done research on the other one I was going to talk about. We won't talk about it. Because you can actually go out and buy this book, and you can actually do it. If you have a patient with this problem. So you could actually train yourself and get maybe some supervision from somebody else who has experience doing these kind of interventions, and you could actually do this intervention. So Miklowitz is kind of one of the leaders in the family-focused, he calls his intervention family-focused therapy, or FFT. And it's an adult intervention that he developed in the 80s and 90s based on research to really help families deal with bipolar disorder in adults and significant others, and including the adult with bipolar disorder. So this is an adaptation from the adult model. These models, again, we're considering these illnesses to be relatively lifelong. They get better, and people recover from them, but they still remain. Symptoms still remain. So they're usually not short-term treatments. This one's 9 months. Some of the other family psychoeducation interventions are even longer, 2 years, are some of the ones that I work with. So family psychoeducation involves helping the family develop an understanding of the problem, remaining focused on successes around kind of communication and how to solve problems, because that seems to be the underlying deficit often for people who have bipolar disorder, is that their ability to communicate in an effective way with other members in their family and other people, especially when they're really ill, is pretty impaired. So if we can teach them really basic communication skills they can use, that helps reduce problems like what Charlie Sheen's going through, right? People really not liking them, people not wanting, or people actually paying too much attention to the problem, reinforcing it. Problem-solving skills are also really important. So teaching folks how to really have a problem, knowing that you're likely to have a relapse of your mania. What can you do now in your life to set it up so that when that relapse happens, you can contain it, control it, and go on with your life? So that, again, I have references at the end of the presentation, is a model that you all can get a hold of and use in your own clinical practice. All right. So the other intervention that I was going to talk about is MFGT, which is you can certainly go online, and they have a toolkit for how to use it online. It requires a little more training. It's a group approach to providing family psychoeducation. So it's somewhere between kind of Miklowitz's intervention, his single family intervention, and a support group. So instead of a clinician necessarily saying to you, you really need to figure out a way to slow down. When you're having symptoms of mania, you got to figure out a way to slow down. You got to get rid of your credit cards. You just absolutely have to get rid of your credit cards. Please don't send in any credit card applications. Can you agree to that? Instead of a clinician saying that, another family member or another person with the illness says it. So sometimes that could be a really pretty powerful thing. So this is an evidence-based approach for adults with schizophrenia that's been adapted for depression and bipolar disorder as well, and has been adapted for mood disorder, children with mood disorder, both depression and bipolar disorder. So here are guidelines. Again, these are based off of research that really understands what predicts relapse. So lower your expectations temporarily. Don't have too high of expectations when you're having an exacerbation of your illness. Really keep your emotions down, keep it cool, give each other space. And it works like this. There's socializing, because people with schizophrenia often have really deficits in social skills. We really focus on socializing. You're not allowed to talk, or the only thing people talk to them about, or the only social context they have, are providers or their family members telling them, quit being crazy. It's not very reinforcing. It's not much fun, and it doesn't help your recovery. So in socializing, no one is allowed to talk about having a mental illness in that part of the group. And then we go around and we get an assessment of how people are functioning overall. And then the clinicians pick a problem that one person's talked about or one family's talked about, and the whole group works together using kind of structured rules and a structured problem-solving intervention, or schema basically, or process. They basically solve a problem solve that individual family's problem as you go through. And that really provides a framework for how families and individuals can solve problems in their real life. So, and then I was going to talk about DBT. DBT is a promising intervention. Just because you have a lot of mood dysregulation doesn't mean you need DBT. If your primary problem is mood dysregulation and you have self-harming behavior, you may need DBT. That's my short end of the stick. A lot of people are seeing DBT as a kind of cure-all for a lot of different problems around emotion dysregulation, which it is. And in addition to that, it's even more effective for people who have self-harm, because that's really its typical target. I was going to talk a bunch about that, but we're out of time. So here are the resources that I suggest you get a hold of that really are good references for assessment and for treatment, including some of the treatment stuff. Again, if you just if you just Google Miklowitz in bipolar disorder, you'll find his book, which is a really great book. So questions, comments?
Kind of like a two-fold question, I guess. Given these kind of evidence-based practices are real deep-end interventions in severely troubled populations, I was wondering about the ethics of things like RCTs. with the population, and how we get past that. And then, I guess, coupled with that, I'm assuming that because this is a rare disorders, sample sizes aren't going to be very big, and what sort of statistical power you can pull down.
So historically, I'm going to answer the second part of your question first, around statistical power. So historically, that's been the case, and that's why the research has been limited. More recently, in the last 5 years, and again, Dr. McClellan, who's in our department, has been involved in a couple of these studies. They've had these large multi-site trials that are, in fact, some of them international, where they've been able to recruit, about 200 kids with schizophrenia. So they have more typical, sample sizes where they do have statistical power. And have found differences. Some of their differences that they found are kind of controversial. So I'll answer the first part of your question. One part of this adolescent schizophrenia study for pharmacology, investigating what medications work, compared medications, the old antipsychotic medications like Haldol, which people have historically thought were not very, had all these side effects, and that's why we came up with all these new nice medications that maybe have fewer side effects, like causing basically Parkinsonian symptoms. But what they found in their study was that there was no difference in efficacy or side effects. In fact, these atypical medications, and this is one area of my research, really cause diabetes. And a lot of individuals exacerbate diabetes. So if you've ever worked with someone who's taken an atypical medication, you can see a weight gain of 30 to 60 pounds in a few months, which is pretty traumatic. If you think about a 16-year-old girl, what's that going to be? I mean, I was a 16-year-old boy. That would have been traumatizing for me. So there's a lot of issues there. So the research is getting better in that sense. So you're right about the standard care placebo. So they have a lot of these research trials have been placebo. They have had a placebo arm. They typically involve ongoing regular care, though, in addition to that. They just can't be taking medication. And then in addition to that, they're typically brief. So they're typically a couple months at the longest. Some of them are even done on inpatient units, but smaller studies, not the big ones. Other questions?
How do you get families to stick with therapy for 9 months, 2 years?
They have to get something out of it. And it's, in my experience with the adult populations that I've worked with, they really do get something out of it. Because often they come to you so overwhelmed and so burnt out by the mental health system that this is kind of a breath of fresh air. And they often, for the most part, most families the family psychoeducation models really emphasize that the provider has an expertise and the family has an expertise and the person with the illness has an expertise, and we're all bringing them together to really inform each other. And so the first part of our intervention for schizophrenia really is focused in on what we call the joining, which is based on it's a family therapy concept basically, where we just let them tell their story for 3 sessions, the patient individually and then the family and then them together. And the clinician really just listens and then has all that information for assessment, and then also to develop a relationship with the family. And then also for the when we move into the intervention phase, we're really giving them advice. We have that kind of rich information about that connection with folks. But the other part of it too, in our intervention is only monthly. So it doesn't really require a lot out of folks. It's not like a parent training intervention where you might ask them to come every week or even more often and do lots of homework. You typically ask them just to call you if somebody quit taking their medication or things like that.
Do they pay for it out of pocket or does insurance?
That's a really good question. On our new billing sheets in the last few years, there is a billable thing for multiple family group treatment or therapy, but no one will pay for it. So no. So basically, you could do it as a group psychotherapy, or you can do functional family therapy as an individual psychotherapy. The patient just is in the room. And just like any other child or adolescent intervention, when you want to meet with the patient for part of the time and the family for the other time, as long as you're within reason, I think most insurance companies and facilities are willing to do that.
Probably have to wrap it up. Would you be able to stick around for 5 minutes if people have questions individually? Can you do that? So that folks can get to class. Thank you very much.
Everybody.